Okay, welcome everyone to our panel discussion on a holistic approach to young people's psychosocial well-being. I'm Nicola Ansell, I'm Professor of Human Geography at Brunel University, London. Thank you to all of you for joining us here at the Overseas Development Institute. This event's a collaboration between Ruth Evans, here from the University of Reading, and Fiona Samuels from ODI, and Morten Skovdahl from the University of Copenhagen, who is somewhere around taking photographs. We also welcome our online audience that's watching via video, and remind everybody in the room that the event will be being filmed. Today we brought together people working in the field of young people's psychosocial well-being, both here in the UK and in the Global South. We recognise that despite increased awareness of young people's mental health needs, interventions that target their psychosocial well-being remain largely medicalised. In reality, young people's well-being is often tied to their family, their relationships with their peers, and to resource constraints within their communities. So our panellists will discuss how the psychosocial approach to well-being can have a significant impact on the social lives, educational outcomes, and future potential of young people. Today's event's timed to coincide with the International Children's Grief Awareness Day, which was on the 17th of November, and also Children's Grief Awareness Week, which runs across the UK until tomorrow. So this week is a chance for us to come together to show our support for bereaved children across the UK. The theme is Make Time to Listen, to make sure that bereaved children and young people's voices are heard. For those in the audience who are on Twitter, please do tweet as the event progresses. I don't know whether the hashtags are shown, are they? Yes, they're on the screen here. So that you can follow use the ODI handle, ODI Dev, to follow the conversation. If you haven't already done so, please switch off your phones or set them to silent. Okay, our first speaker this morning is Richard Bowden, who is policy advisor with DFID's disability team. Richard leads DFID's work on mental health and work to support young people living with psychosocial disabilities. Prior to this role, Richard worked in DFID's youth team, leading the work on the youth agenda, particularly focused on the role of young people as agents and advocates in development. Today, Richard will talk to us about DFID's approach to young people's psychosocial well-being, care and support, and the social context of young people's lives, families and communities. So welcome, Richard.
Thanks very much, and thank you for having me today, and thank you everyone for being here. So yeah, as I was just introduced, my name is Richard Bowden, and I currently work in DFID's disability team. I think what's really important to start by saying is that this issue sits across several teams in DFID, so it doesn't sit within one team. So I'm in DFID's disability team, but it's obviously also an issue that cuts across our health work, cuts across lots of different issues, but it sits, I guess, across this disability, health, and youth team. But I can mostly talk, I can mostly talk about DFID's disability work, and then also touch on some of the work we do through youth. So what I was going to talk about a little bit was about the policy framework that DFID has in place to support young people's psychosocial well-being, talk a little bit about what we mean by disability, and talk about young people and disability, the particular challenges that young people face, and how we try and go about addressing some of these challenges, how DFID's work tries to go and address these challenges, and then talk about what's next. So huge opportunity for the global goals, but there are lots to do, and what is that? So to start off with, I wanted to give, a little plug. So DFID has a disability framework, and that sets out what we do on disability. It sets out our ambition. We first published it in 2014, and then revised it in 2015. And what we're saying in that document is that people with disabilities should be included in and benefit from all international developments and humanitarian assistance. In this document, in 2014, we set ourselves quite a high level of ambition. So disability, I'm sure as many of you know, is one of the most underinvested, underprioritised issues in development. In 2014 was I guess our first public document in stating that we wanted to do more on it. And it's also meant to be quite a practical roadmap. So it's in this document. I've got copies if anyone wants to see it afterwards. It also sets out an action plan in certain areas of what we'll do on disability in terms of policy, in terms of programs and external influencing. In 2015, we revised it. We wanted to do more around three particular areas: economic empowerment of people with disabilities, tackling stigma and discrimination, which is huge for people with disabilities, and then finally, mental health, which again is disability is one of the most underprioritised and underinvested areas. Mental health even more so. So what do we mean by disability? So we're guided by the Convention on the Rights of People with Disabilities, but we're also guided by the UK Equality Act. The UK Equality Act 2010 says a disabled person is someone with a physical or mental impairment which has a substantial and long-term adverse effect on their ability to carry out normal day-to-day activities. Now, obviously, psychosocial disabilities is complicated, but the reason why I wanted to say that is because our work on disability is not just physical. A lot of people, I think that the work on disability can be just physical, but it's also mental as well. Some of the big stats: 60% of the 1 billion people living with disabilities have psychosocial disabilities. By 2020, the World Health Organization estimates that mental health conditions will account for 15% of the global disease burden. However, investment in mental health is incredibly low. On average, low-income countries allocate just 0.5% of health budgets to mental health. Too often as well, mental health is viewed merely from a medical perspective, not from a social perspective and not in terms of people's overall health and well-being. People with disabilities, people with psychosocial disabilities have little voice or control. Often there's severe violations of their human rights and there's massive stigma and discrimination. Now, the focus of today is on young people. Young people are at particular risk. Half of all lifetime mental disorders start by the age of 14. So it's clear that there's there's quite a strong policy framework, but it's also clear that it's massively underinvested. But we have a real opportunity with young people, and the demographics alone are enough. Half of the world's population is under 30 years old, and 1/3 of the world's population are children. So we have a huge opportunity as well as a challenge. So what is DFID currently doing around these issues? Like I said, it cuts across lots, but I wanted to just bring out a couple of examples. So in Ghana, we have a £6 million programme that works that invests in the mental health system. It's trained 3,800 healthcare workers around mental health, and it's treated 80,000 people. And it also has a big component around stigma and discrimination. We have a big research programme that focuses on mental health care in emergencies, looking at 8 different research projects over 6 years. We do a lot of work around violence against women and girls, and access to justice and psychosocial support and counselling. And we do a lot of work around inclusive education and economic empowerment. And then finally, what a big part of our work, our team's work anyway, and we don't have a lot of funding actually, but our team's work focuses on disabled people's organisations, so providing funding directly to disabled people's organisations through the Disability Rights Fund in particular. So I've given you a bit of an overview of what we currently do, but I think, I don't want to overstate it really. We don't do a lot in this area, and the disability framework was a good starting point, but I think we could go a lot further. I think we could do a lot more, particularly around mental health. But I think the global goals gives us a really good opportunity to do that. So the global goals could be truly transformational for people with disabilities. So no goal will be met unless it's met for everybody, no matter who they are, no matter what ethnicity they are, no matter what gender they are, no matter whether they have a disability. So we could do a lot more. We and the other donors, the international community, can do a lot more. So what could we do, or what can we do? So we need to mainstream the issue much better across our portfolio. So I recently undertook a mapping of all our work on disability across DFID, and we mainstream disability across about 72 programs. So whether that's health, education, economic development, social protection, whatever. But we need to do it. We need to do it a lot better. We've got far more programs than 72 programs, and we need to learn what works. So in a lot of these areas, inclusive education, it's really difficult actually. We don't know whether it works from a systems approach or it works working lower level. On economic opportunities, what works. So we need to do a lot more on generating evidence and then using that evidence. It's also really important that we practice what we preach. So within DFID as an organisation, we should do a lot more in terms of being an inclusive workplace. We set up a network last year. It's called the Listening Network. It's a really it's a small thing, but I think actually it's really important for us as DFID staff. So there's a list of people, and you can kind of if you ever feeling life is difficult or you want to speak to somebody, then there's you can reach out through that listening network, completely kind of voluntary that staff do. But also practicing what we preach in terms of our programs and in terms of our existing commitments. Really important is we need far more international leadership on disability, on psychosocial disabilities. We are globally, DFID is seen as one of the leaders on disability, and actually, like I said, we don't do a massive amount on disability. Disability frameworks are a huge step forward, but there's a lot more we could do. So that, I guess, that demonstrates the real lack of leadership in this area. So we need an international system that really works. And then I think what's really critical is around data, because we just don't know who we're reaching. We don't have good data at all on understanding who people with disabilities are, and if they're not counted, then they won't count in how we do our programs. So we really push the Washington Group questions, which are a group of the basic level is kind of 6 questions that don't ask a binary, are you disabled, yes or no. They ask 6 questions which don't even mention the word disability, and it's to find out the true figures. For example, when those figures were not used in Sri Lanka 10, 15 years ago, the figure was 1-2%. When they were used 10 years later, I think this was through the census maybe, the figure was 12%. So it was 1-2% when the figures weren't used, is the people that kind of said they were living with a disability, and then it rose to 12%. And the average globally is around 15-20%. So we need much better data to understand the scale of the challenge and then to address it. So I've tried to just set out a bit high level some of the issues, where we're coming from DFID. We've got a good policy framework, but we can do more, and then the areas where we can do more. Thanks very much.
Thank you very much, Richard, and thank you for your overview of what BFID is doing in this area. I'm now very pleased to introduce Dr. Fiona Samuels, who's a research fellow with the Social Development Programme here at ODI. Fiona's a social anthropologist with over 15 years of experience crossing the fields of social development and public health. Her research interests include social protection, gender-based violence, mental health and psychosocial well-being, and the role of gender and social norms in addressing the needs of vulnerable groups, including women, adolescent girls, children and older people. Today, Fiona will be presenting on the Social Development Programme's recent work in the area of mental health and psychosocial well-being for children and adolescents in a range of different contexts. So thank you, Fiona.
Thanks very much, and thank you everybody for being here. It's great to see such a nice audience. So I'm going to talk about three things in this presentation. Firstly, I want to look at why and how we in the Social Development Programme here at ODI have come to focus on mental health and psychosocial well-being. And I want to stress that we're actually talking about not severe mental health disorders. We're talking about the less severe forms, which include issues around anxiety, depression, loneliness. The second area that I want to touch off is to discuss a range of drivers of mental health and psychosocial well-being which have come out of our various studies and which help us also to think through a little bit about how we could frame this area of work. And finally, I want to look at the kinds of responses in the service environment which is out there in relation to these issues, and again, coming out of our various studies that we have been doing here. I also wanted to mention that this presentation comes in the wake of me attending the American Anthropology Association conference, where we actually pulled together a theme on this topic, a panel on this topic entitled Mental Health and Psychosocial Interventions in Contexts of Violence, Conversations Between Anthropology and Public Health. And I also attended various sessions on that, and it actually got me thinking a bit in more detail about what we're actually doing here and how we're thinking about it and sort of possible ways forward. So firstly, how did we come to focus on this area? So in this program, as many of you know, we cover a wide spectrum of research areas, ranging from working on social protection to work on children and adolescents, to working on issues around gender-based violence and sexual and reproductive health. And we do this in a variety of geographical contexts, but also ones facing different degrees of fragility, including some post-conflict settings. A theme which kept emerging from these studies, but was actually never given centre stage until more recently, was the issue of mental health and psychosocial well-being. So, for instance, in a study on cash transfers in Kenya, Uganda, Palestine, Mozambique, and Yemen, we heard from a whole range of respondents, and despite the shortcomings in these cash transfers, that they actually helped people to breathe again. They relieved some of the everyday stresses and tensions that affected people's mental health and psychosocial well-being. And amongst other things, we recommended that indicators for mental health and psychosocial well-being should be built into the programme monitoring and evaluation. In another study in the Terai in Nepal, very different areas, the loneliness and isolation of girls marrying young through largely arranged marriages came out very strongly. The fact that they had no one to share with and no one to talk to when living in their in-laws' homes strongly affected their mental health and psychosocial well-being. The arrival of children, even if they were bearing children very young and having to drop out of school to do so, was a respite from this loneliness and isolation. Similarly, in Vietnam, a young woman who had married this time by love and according to her own choice, had ended up living with a man who she didn't know very well and who it seems was abusing her. She regrets her desire to marry young and drop out of school and is unable to leave him, fearing that she will lose her children. She also faces loneliness, depression, and anxiety that she will be beaten and that her children will be affected. If it weren't for her children, according to her, she would most likely take her own life. On a more positive side, and despite the dangers of social media and particularly the penetration of mobile phones into many areas, in Nepal, these mobile phones also act as a means of support and communication, particularly for young women who are married and living in their in-laws' houses, thus also contributing to enhance their psychosocial well-being. There are also examples of supportive teachers in all of our study contexts supporting the academic studies of children and acting as go-between between parents and children in many cases. Other studies that we have carried out and continue to focus on exploring how gendered norms affect the life choices and trajectories of adolescent girls. As these and indeed other studies have shown, Adolescence is a pivotal stage in the life cycle where an individual's experiences shape their future opportunities and responses to life's challenges. This stage has until relatively recently been ignored, neglected, and often stigmatized in many developing countries, with entrenched and discriminatory gendered norms stemming from childhood and becoming acute in adolescence, restricting girls' behaviors and limiting their opportunities. Some particularly neglected aspects are their psychosocial and mental health needs. In adolescence, such needs are intensified as people face multiple interrelated physical, emotional, and psychological changes. Thus, in a context such as Sri Lanka, for instance, service providers adopt judgmental attitudes strongly influenced by gendered norms and notions of appropriate moral conduct of adolescent girls, which resulted in their primary concern being to address risks and to provide protection for these girls, rather than deal with their psychosocial well-being. Similarly, in Gaza, service providers suggested to parents that they should no longer bring their daughters to see them, since this would affect their future marriageability, despite the fact that they may have been facing mental health and psychosocial distress. All of these kinds of findings have led us to focus now more and more on the issues of mental health and psychosocial well-being, also taking into account and drawing on some early and broad definitions of mental health, wherein mental health is not equated simply as the absence of mental disorder, but includes subjective well-being, self-efficiency, autonomy, competence, and resilience of and realization of one's potential. This is a WHO definition. Turning to my second broad area, now I want to briefly explore what these drivers of mental health and psychosocial well-being are and try and categorize them, but also bearing in mind that these categories are fluid, cross-cutting, overlapping, and layered. And in a sense, what I have just outlined above also highlights the overlapping complex nature of these drivers. So on the one hand, there's a lot of literature and interventions from the humanitarian world on mental health and psychosocial well-being. And in fact, one can argue that the humanitarian actors have pushed the broader development community to think about and conceptualize psychosocial dimensions. Thus, conflict and post-conflict settings, as well as those which face different forms of fragility, including those resulting from natural disasters, can be drivers of mental health and psychosocial ill-being, and typically PTSD and trauma are symptoms of this. Thus, in some of our studies, for instance, Vietnam and Sri Lanka, although the conflict had to all intents and purposes come to an end, and particularly the children and young people in our sample had not experienced it directly, it somehow remained a presence or a shadow in their lives, influencing their relationships with their parents and with others around them. In places such as Palestine, this fragility was more concrete and present every day, with PTSD and trauma a common symptom experienced by many people. Although violence is often part of conflict and post-conflict settings, it is also important to highlight it as it can also include gender-based violence, sexual violence, as well as broader notions of violence, all of which can lead to mental health and psychosocial ill-being, and which can also be cross-cutting. Migration, which can result from conflict and other forms of fragility, but can also include economic migration, both internal and international, can also lead to poor mental health and psychosocial ill-being. As people are displaced, they do not belong, they may lose their sense of identity, they may be in a liminal state, and so on. And again, there's a lot of literature on that. In our studies, migration of parents in Vietnam and Sri Lanka, for instance, and particularly women in Sri Lanka, was a critical factor which affected the well-being of children and young people left behind. The pressures of everyday life can also create mental health and psychosocial stresses, and perhaps this is the largest category, as these pressures can include and range from poverty, death, bereavement, grief, academic pressure, pressures to live up to expectations, and stresses imposed by expected ways of behaviours, including norms, which are usually gendered and discriminate girls and women more than boys and men. Substance abuse can also lead to mental health and psychosocial ill-being, but it is also a reaction to or coping with these pressures. In all our studies, these issues, or the pressures of everyday life, including norms affecting attitudes and behaviours, were paramount. And arguably, it is these themes which are also cross-cutting, that are also much of the focus of our work here. Other cross-cutting features are gender and age, with women and men both reacting and being at risk differently, and similarly different age groups being at risk and behaving differently. Similarly, there are particularly vulnerable groups, which can cross-cut the above categories that I mentioned, and who can be more at risk of mental health and psychosocial ill-being. These include children, adolescents, ethnic minority groups, and groups with special needs. We just heard about disability. So the final I'm turning now to my final section, where I'm looking at the responses and the service environment. And before talking about that, I just want to mention this is talking about formal responses, and there are a range of informal responses that people in our study talked about. And there are different levels of resilience, but actually interestingly, although perhaps not so interestingly, the resilience around sort of psychosocial well-being tends to be quite limited. So as I have started to suggest, and despite very different kinds of services environment, degrees of government and non-government involvement and budgetary allocations, thus, for instance, in Gaza, there are a wide range of organizations, including NGO and donors, providing mental health and psychosocial services. In Vietnam, while NGO services are negligible, the government is leading the mental health response. And in Liberia, just to name three of the countries where we have started to focus on these themes, these services are more or less non-existent. So despite these very different environments, we have found a number of also frequently shared shortcomings. To summarize a few here, where service provision does exist, it tends to adhere to a biomedical approach and paradigm, largely ignoring social and political context, with cadres of adequately trained counsellors, psychologists, psychiatrists being very few and far between. Even where these cadres do exist, people are reluctant or do not use them for a number of reasons, including they may not know of their existence, they often want to treat at home first, and the stigma associated with accessing such kinds of services, as also mentioned above, with even the service provider not wanting to further treat a girl of marriageable age for fear that no one will marry her if they found out she is accessing this kind of service. Where services do exist, they are often not tailored to children and adolescents, nor do they deal with the differing needs of girls and women and boys and men. And even within the health profession itself, according to our respondents in Vietnam, for instance, people did not want to become mental health doctors, as it was an undervalued field of medicine. More generally, there was a sense from many respondents that mental health and psychosocial well-being, and particularly the less severe forms of mental health challenges, which also affect the majority of people, are not sufficiently important enough to warrant spending time and attention. There was a sentiment that people should just deal with them themselves. From a policy perspective, many of the countries in which our studies took place have a positive policy environment or future plans to incorporate aspects of mental health and psychosocial well-being. However, the implementation of these policies remains challenging, as does allocating sufficient resources to them and ensuring adequate collaboration and coordination amongst key government departments and other stakeholders. And raising awareness of the importance of focusing on such aspects at all levels is also critical. So I just want to end my presentation here with a word of caution, and this also comes from hearing some of the presentations at the conference that I just attended in America. And there is a sense, and I can also understand this, and as I have also been grappling a bit with this myself, is that we may be overloading the concept of psychosocial, and sort of lumping too much inside it, so that it actually may end up losing its meaning and end up being associated with everything and anything. And I also acknowledge that I myself may be falling into this trap. So I think going forward, it will be critical to be clear about it and to tread very carefully when thinking about the kinds of policies and programs which might address these issues. But at the same time, I think it is critical to push back on the over-medicalized approaches which invisibilize the complexities of the context and social interactions, which are both often at the heart of the drivers of mental health and psychosocial vulnerabilities, but are also a critical response, are of course critical in the response. Thank you.
Thank you very much, Fiona, for an enlightening presentation there. And also thank you for hosting us here at ODI. Next up, we have Ruth Evans, who is Associate Professor in Human Geography at the University of Reading. Ruth's research focuses on young people's psychosocial well-being, young caregiving and family relations, particularly in relation to bereavement, chronic illness and forced migration. At Reading, Ruth's the leader of the Participation Lab, which is a hub of expertise in participatory action research methodologies and aims to co-produce knowledge for social impact. Today, Ruth will be presenting about bereavement and how it's crucial to engage with family and community support networks, drawing on her research in urban Senegal. Welcome, Ruth.
Okay. Thanks, Nicola. It's great to be here to be able to share with you some of the key kind of messages really from our research in Senegal. I mean, I particularly wanted to focus in this presentation on thinking about bereavement, but how it affects children, young people and adults, and really to emphasise the importance of understanding the family context really of young people's lives. So, I mean, we're coming at this really from the point of view of thinking that death is not just an economic shock, as it's often referred to in the context of the Global South. And there's few studies really that explore the everyday significance of death in young people's family lives and in their imagined futures. So it's really important to understand the family context, family meanings. And this also builds on my previous work, which was looking particularly at caring relationships within families affected by HIV in particular, and how young people often take on active caring roles, even though they may be constructed as being dependents of adults. Young people are often involved in reciprocal caring responsibilities towards their families and their communities, and these caring roles are often gendered as well. Girls often have to do much more domestic and care work compared to boys, but boys are also involved in caregiving. And this also needs to be understood in the context of the kind of mobility of many households, particularly in African contexts. There's a lot of fluidity and movement between households, and fluid kind of ties of kinship and household membership. I mean, social ties of marriage and sort of extensive shared social experience may be sufficient to be regarded as kinship and household membership. So if we look particularly at our some of the messages from our research in urban Senegal, I mean, we did interviews with 2 members of families, and before that we did a kind of family profile, and we found it very difficult to distinguish, to really work out who lived where and the kind of different household structures that were involved. We often got different accounts from different family members. And relatives may be part of the household during the day, but then go to sleep somewhere else. They may share meals together, etc. In the majority of the families where we did our research, most lived in large households. So 11 families had 6 to 10 household members, 9 had 11 to 20. I think we had one where there were 35 household members, and only one single person household. And I think, I mean, Senegal perhaps is that households are larger perhaps in urban areas in Senegal compared to some other African countries. But this also goes alongside a long-standing tradition of child fosterage practices in many African contexts. In Senegal, about 13% of Senegalese children under 18 are sent to live with a host family as part of child fosterage practices. And around a third of households either send or receive fostered children, and that is often reflected in other African contexts as well. So really what came out from the research was really the strong interdependence of family ties and responsibilities. Family members rely on each other for daily survival, for their emotional and practical support, as well as opportunities to really sort of succeed in life and to manage in times of crisis. And this solidarity and kinship often could also include neighbours. You can see from the quotes on the slides there, you know, people felt very strongly that neighbours were very much part of their family. And so individual and family well-being was dependent then on intergenerational as well as intragenerational relationships. So relationships between siblings were particularly important. Children recognise the authority of older family members, elders who provide advice about how to sort of function within the family. And sibling relationships, of course, continue throughout the life course and were important to adults as well as to young people. And there are often assumptions about the values of a respectable family which were related to gender and age. So, for example, children were expected to stay at home in the evenings. Women particularly were expected not to go out too much, not to gossip or meddle in others' affairs, particularly during widowhood kind of mourning period. And the values of practicing your religion, valuing education, bringing up your children to share these kind of values. So I think, really to understand the significance of the death of a relative, you need to understand this kind of family context. And in terms of the impacts of bereavement, we've kind of talked about the way that the social, the economic and the emotional impacts are all really intertwined. I'm not sure the figure really does justice to how sort of interwoven they are. And you can see some of the examples there. We've kind of separated them out there, but really they're much more overlapping and interconnected. So the economic impacts, dealing with poverty following the death of a relative leads to a lot of anxiety about survival, and that can and exacerbate then the emotional aspects of bereavement. So really, what we want to argue is that the economic, the emotional, the social dimensions of a family death are really interwoven, and they do shape young people's gender transitions. And really we're sort of proposing that a sort of bereavement-aware approach is adopted, which goes beyond just focusing on the individual or the household. It's a much more family-focused approach, which understands the crucial importance of engaging with these extensive, quite complicated family relations and community support networks, which is what people relied on after a family death, rather than any support from NGOs, which was largely non-existent for most of the families that we interviewed. And our full report is available to download from our blog. Okay, thank you.
Thank you very much, Ruth, for rounding off our panel today and for keeping to time very well. I'm now going to hand over to Lynette Mudakunyi, who is our first discussant. Lynette is the Acting Chief Executive Officer of the Regional Psychosocial Support Initiative, or REPSI, based in Johannesburg. And we're very pleased that she could travel from South Africa to be with us here today.
Thank you very much. As I've been introduced, I'm from REPSI, which is the Regional Psychosocial Support Initiative. Our headquarters is in South Africa, but we work throughout East and Southern Africa and have been for nearly 15 years now on psychosocial support. So it's very exciting for me to be part of a whole day which is discussing psychosocial well-being, because when we began, that was a term that was not very well understood. And in our part of the world, even 15 years later, probably isn't so well understood. So it's very interesting to look at it from three quite different angles, as we have this morning, to think about psychosocial and mental well-being, as well as psychosocial and mental vulnerabilities. What we haven't had time to look into so much is what promotes psychosocial and mental well-being. We did look a little bit at what are some of the drivers of vulnerabilities, but what is it that promotes well-being? And how can we build well-being into children before they become adolescents? Because adolescents don't just wake up one day and they're an adolescent and they are facing psychosocial vulnerabilities. They've been children for several years before they got to that point. And how can we shore up, if you like, the well-being within them so that when they are facing vulnerability, they do not go into psychosocial disability, for instance. And I'd really like to ask our panelists to think about that, to think about what are the family, the community, and the services that are available, and how do we bring about the coordination that we did mention that is so necessary. And look at that across promoting well-being, preventing disability, and responding to mental and psychosocial non-well-being, if you like, problems, disabilities, when those occur. How do we have those services in place in a way which is not stigmatizing? Because the stigma is such an issue for all of us, always. Which are the services which are available, which are the community structures that are found in different contexts? How can we bring those together to support children, to support adolescents? Of course, remembering that you can't support them outside of their families. So how do we work with families to make this stronger? And if we're looking at services and coordinated services, what kind of training do we need for those services? Is our training for those services currently adequate? Our pre-service training? Are we even mentioning issues of psychosocial or mental well-being as people are being trained? Or are we expecting that we will have specialists for this? Is it enough to expect for specialists, or do we need some basic training for all of the people that are going to be working with children, youth, and families? And so those are the questions I would like to pose to the panelists to think about.
Thank you very much, Lynette, for some very insightful comments and questions. We now move on to our second discussant, who is Alison Penny, and she's the coordinator for the UK Childhood Bereavement Network, or CBN. The CBN is a hub for those working with bereaved children, young people and their families across the UK. Alison coordinates the work of this CBN, based at the National Children's Bureau, managing activities and raising funds to bring about change for bereaved children and their families.
Thank you very much, Nicola, and thanks so much for inviting me today. And it's been so interesting already to hear about approaches to addressing psychosocial needs, both at a policy level and at a programmatic level, and then at the very specific example that Ruth has given us of the families that she was working with and studying in urban Senegal. And as the panelists were talking, I was thinking about the theme of loneliness that came out quite strongly, particularly in Fiona and Ruth's presentations, both as a driver and as a marker of mental health difficulties and as an aspect of psychosocial challenge to young people, to children, and also to adults in those children's lives. And it chimes very much with some findings that we have just published at the Childhood Bereavement Network in the UK context, looking at how children and young people who have experienced the death of a parent, how they deal with their worries. And we have found that they deal quite differently with their worries, in that they are less likely to share them with a friend or a family member, and they're more likely to keep their emotions to themselves. So that has kind of made me think more about, again, the social aspect of bereavement as one of the transitions that young people may be going through in childhood and adolescence. And as we know from the work of Jane Ribbons-McCarthy, that is the majority experience of young people in the UK and beyond the UK. So if we know then that loneliness is one facet of the bereavement experience, and that it can contribute also to how young people deal with that experience, how do we make that sufficient to warrant intervention? Is it sufficient to warrant intervention if we know that loneliness potentially contributes to mental health difficulties for children and young people? And I thought that Fiona's point around what is it that makes psychosocial challenges sufficient to warrant intervention was a really key challenge to all of us about how is it that we understand what we should be doing in response to some of these changes in children's lives. One of the ways in the global north that has been addressed is through attempts to draw out what is normal grief and what is complicated grief. And there have been some huge debates about the degree to which these are internal differences or whether they are differences to do with the social context in which children and young people are finding themselves. And the definition that is proposed in the American Psychiatric Association's inventory of mental disorders is that complicated grief has to be defined as a response that is beyond what would be expected through the culturally expected norms of grieving. And yet, how do we actually define those norms at all? Are we listening sufficiently to children and young people about the impact of changes in their lives and of affecting the entire household? And to what degree are we actually putting the social into those understandings? Ruth's diagrammatic representation of the different impacts of bereavement within the families that she was studying in Senegal, looking at economic support, at the social support and emotional support and the impacts therein, I think is a really helpful framework. And it would be good to hear more about the ways that representation of the interrelatedness of those approaches can be used both to drive policy and to drive programmatic change as well. One thing that we could think a bit more about as well is the influence of peer support and how approaches to peer support can be encouraged and to what degree that needs to be organised at an interventional level. We've found in talking to children and young people who have experienced bereavement that meeting with others in the same circumstances or in similar circumstances has been hugely powerful, not least because to some degree it helps them to realise that there are others in the same situation, but also it gives them positive ways of coping, and it also helps them to understand that they can support others through this experience. And so going back to that theme of loneliness, to what degree can we use particularly peer support approaches to support children in dealing with these transitions in their lives? So I think what I'd like to hear more from the panel is following on from Lynette's point about what are the drivers of well-being and how can we build that into children's lives. Thinking about the ways that we can ensure that the global goals are used as policy drivers to improve support for children and young people, and that we think about what degrees of organisation for interventions actually can support those changes that could make a material and an emotional difference in children's lives.
Thank you, Alison. I'm now going to invite the panellists to respond to one or two of the points that have been raised by the discussants. But we're going to move on from that to audience Q&A. So I'll ask the panellists to be brief in their responses. So Richard, would you like to go first again?
Yeah, sure. I mean, a number of those questions are way beyond my level of expertise, but there was a few questions that struck, I think, in terms of what promotes well-being. So one thing, particularly as I learned through being in the youth team in DFID, is that children, the importance of play for children is so important. And in a lot of the countries and the contexts we work in, children don't often get to play in the same way that children in this country do. Often, whether that's through kind of doing household chores or through supporting with the family business or with work or whatever, but play is so important. I've got a friend who built a playground in Addis in Ethiopia, and it's just something you don't see very often. Is a playground and children playing in the same way they do, and I think that's so important, particularly as a really early stage. Then there was the question around around how do we kind of support psychosocial wellbeing at the family community services level. So at the family community level, a big thing, and it's the same on disability policy, which I mentioned already, is around tackling stigma and discrimination. But I think we don't anyway in DFID, we don't understand enough about it. So we don't understand enough about what's the best way to try and tackle such a deep-rooted issue particularly around disability. I think there's or mental health. There's issues we can learn from other areas, whether that's HIV, stigma, or other things. But it's something we should do. And then around services, I mean, again, talking about disability, mental health, rather than focusing on psychosocial well-being, is around an inclusive education. So it's so important that people can access education. How do you best go around that? Is that teacher training? So teacher training to be able to support children with disabilities, to support people with mental health issues or psychosocial disabilities from bereavement, like we've talked about. And then the integration of health services with that as well. I think our health work tends to focus on quite a high level. It focuses on system strengthening. I don't know enough about how that kind of bottles down, but I think it's really important that we kind of, once we get past the stage of we've got a functioning health service in a country, then how do we make sure that service actually has support for a variety of different health issues, not just a small number of them. And I think that was it. And I completely agree on the global goals and the importance of them. I think we're still, in a number of areas, still working out what that means, whether the best way of doing it is through a global partnership on a certain issue, whether that's on children. There's a global partnership on children, violence against children. Or it's through other ways, through increased investment. On disability, I think it's a number of things. It's increased investment, it's increased action, it potentially could be a partnership, all this sort of stuff.
Thank you. Fiona.
Thanks very much for the great comments from both discussants. I think it's really interesting to hear about this UK context or global north context, where actually there seems to be a lot of similarities from some of the findings that we have been finding in our sort of countries beyond the global north that we've been working in. And I think this issue of sort of normal grief versus complicated grief, that's really interesting, because as you were saying, it's very much, sort of based in sort of cultural norms or expected norms around grieving, and what are they? And I think that's something that we are sort of struggling with within our studies. I think a lot of what we do in our studies is also to ask people, what promotes well-being. Looking at cases where there are sort of, if you want to call them positive deviants, but how come some people are managing to do better in these areas than others? And people, respond in a whole range of different ways. So yes, leisure activities was a key thing, whether they're at school or outside school. And as we were saying, sort of the role of friends and sort of peer networks was critical amongst these young people that we were speaking to. And sort of the whole sort of dynamic of somebody marrying young, being pulled out of school, all that dynamic sort of stopped those sort of peer networks from developing further, because a lot of the peer networks are developed in a sort of school environment in many of these countries. Again, I think we heard that positive role models were critical, and these could also be men for young girls, positive male role models who would be supportive of girls, and they acted as sort of key opening pathways for these girls, and they would also talk to the boys and men in the lives of these girls who often restricted sort of girls from achieving their sort of aspirations, which clearly had a effect on their mental health and psychosocial well-being. A lot of the literature also talks about family connectedness as sort of being supportive of children starting off well. Sort of if there is sort of family connectedness, there's sort of healthy emotional relationships between different family members. So these are all kinds of different types of protective factors and responses. I think in a sort of more policy environment or sort of more programmatic environment, I think what also often seems to get missed out of the programs is going into the underlying nature of some of the sort of the causes of psychosocial ill-being. And these are often, related to everyday stresses and also issues around norms and gender norms and how they affect the lives of children going forward. And I think a lot of as a basis, a lot of programs need to sort of work on these sort of broader issues as well, and a lot of awareness raising at different levels around from community level members all the way up. And I think Ruth's framework of sort of showing how the economic drivers are also vital in all of this, because poverty is such a huge stress sort of factor in these contexts that some of our studies have also shown. So I suppose I'm sort of answering a bit sort of roundabout, but I think a lot of our work has particularly focused on, what could be the recommendations that we would give sort of programmers and policymakers going forward in terms of this type of approach. So I'll stop there.
Okay.
Thank you.
Thanks, both discussants, for really interesting points. Just to come to the normal and complicated grief and, the kind of cultural norms of grieving. Obviously, this is a key issue we've been looking at in our study. And I think what we're kind of recognising really that emotions are produced by cultures, and we've tried to kind of step outside some of the theorising from the global north and really look at what the data, what expressions people are using. And one of them, which comes out very often, and particularly by young people, is this sense of feeling alone, loneliness. But alongside that, you've also got the young people wanting to protect other family members and kind of not wanting to upset other people within the family. So although bereavement can make some relationships closer, I think, and caring often does that too, but it can also mean that there are tensions within families as well. And similarly, I would say in terms of protective factors, religious faith seems to really help young people and adults to come to terms with the death. But religion can also place pressures on young people in terms of the expected sort of expression of grief. I mean, in our research, a lot of people talked about how, they weren't supposed to cry. They were told by lots of people not to cry. But in terms of kind of how to support young people, what promotes psychosocial well-being, then I think maybe strengthening family relationships, understanding those complicated family relationships and the different ways that different family members provide support, which could be economic as well as emotional or spiritual. And also maybe strengthening some of the local community associations. Some of the women we interviewed were members of women's groups. Young people, again, were part of youth associations. And for the poorer families who maybe often had fewer kind of family networks to draw on, these local community associations were a really important source of kind of assistance in terms of dealing with the aftermath of a death. I think I'll leave it there. Thank you.
Okay, thank you very much, Ruth. So we now invite the audience to ask questions of our panellists. I'll take those questions in groups of 3 or 4. Please tell us your name and organisation and keep your question as brief as you can. And also please make sure that you speak into the microphone so that other guests and online audience can hear you. Do we have microphones somewhere? Great. I'll also encourage the online audience to submit any questions to the speakers now. It's great to see we've got some questions coming through already from all around the world. So, okay, so who has a question to begin with? Someone, one here?